So this morning's plenary is the plenary session that will be taking advantage of many aspects of care planning and process and how we organize that. But we're starting a little bit differently from what is in your agenda. Because of a lot of questions and issues around immunizations, we're going to do at least a 10-minute presentation to start off to focus on the current situation of immunizations as well as myths and beliefs. I think it's a worthwhile thing for us to do, and graciously we have someone here that can do it for us. So Dr. Roberto Bert Johannson, who is a new board member of NHMA and an associate professor for critical care in pediatrics in El Paso, Texas, has graciously agreed to do this for us. He's the medical director of the Center for Against Sexual and Family Violence. He's a graduate of Yale undergrad. He's an MD, PhD from Columbia University, and most of his research is on immunology and vaccine delivery. I forgot to introduce myself, but I think some of you know me. I'm Judith Flores. I'm the current chair of the National Hispanic Medical Association, and I have great pleasure to be here and introduce this spectacular panel. So I would like to start with Dr. Johannson, and we can give him a warm welcome.
Good morning. This talk was originally designed for pediatric residents, and it evolved into a tool to be used by anyone caring for children. One of the things that we have all been confronted with is parents who don't want vaccines. And they will quote to you pseudoscience, myth, and fear. So I've divided this talk up into provider myths, patient myths, and parent myths. You will see the talk also includes references and links. I will hope this talk will be distributed to you. I'm working with Ben right now to make sure that happened. So when I go by those slides, don't be alarmed. Hopefully you will get this, because this is an ongoing tool. So in disclosures, I do need to let you know that I've taken money from just about everyone, including BARDA. You fund my lab, I'll talk to you. And I'm also married to a Mexican drug dealer. My wife works for Xenoport and Amarin. She sells some really interesting medications that actually help improve the life of Hispanics. Okay. I also need to let you know that I hold 4 patents for the design of a novel influenza vaccine, and currently in clinical trials. You might have heard them, the universal vaccine trial against influenza. My vaccine's included in there. And it's the vaccine that's currently on the market is known as Flublok. It's really interesting because it's not made in cells or in eggs. It's made in baculovirus, which is an insect virus. So the background here, as I mentioned, a lot of people have different misconceptions, including us as healthcare providers. So I want to go through this, and I also would like to get feedback from you if you're hearing some things that we haven't covered. So I already mentioned I'm going to give you information and links and resources. So let's start with the patient myths. Thimerosal causes autism. Thimerosal, as you know, is a form of inorganic mercury. The fear was increased after the photographs from Minamoto, Japan were released, where fishermen's children were were born with the effects of high levels of mercury. If you haven't seen those photographs, they're worth seeing. They indeed won the Pulitzer Prize. The issue there is that the factory was dumping inorganic mercury into the bay, and the fish were converting it to organic mercury. The fishermen's children were eating those fish, and the pregnant mothers were too. But thimerosal is very different. And I will also show you some data where looking at pre- and post-thimerosal in vaccines, there's been no change in the diagnosis of autism. And interestingly enough, since 2001, when a lot of this what our Jewish friends call the mishigash got started, there have been no thimerosal used in conventional vaccines. But even prior to that, there's less mercury in all of the vaccines a child receives from birth to 12 years of age than in a single can of tuna. Look, I'll get this to work. There have been studies that have also shown, not just in the United States, but in Europe, And the reason I bring that up is there has been a movement within the anti-vaxxer community saying that we in the United States are controlled by Big Pharma. The data from a Danish population showed that there was a negative ecological evidence between thimerosal and the occurrence of autism. The conclusion was that the discontinuation of thimerosal-containing vaccines in Denmark was followed by was not followed by an increase in incidence of autism. And again, you'll be getting these slides. This is where they showed where they're looking at the incidence per 1,000 people, and the increase was actually increases in disease because people were refusing the vaccine. So there was more disease than there was autism. So again, these will all be references. There's also a myth that ingredients in vaccines are harmful. And the answer to this sometimes is yes. When I first started medical school, Professor Fulginetti, who is of RSV fame, mentioned that everything we give, the most powerful, most lethal tool that we have in medicine is this. We write prescriptions. How did Stevie Wonder lose his eyesight? He was premature, and back in the 1940s, you were placed into a box and given 100% oxygen. He has retinopathy of prematurity. Without oxygen, we all die. But at 21%, it's helpful. At 100%, it's fatal. So when you see these meds and people confront you with, oh, that's a dangerous medicine, but at the level it's being given, it's not. But one of them is aluminum. And indeed, we consume more aluminum from our Teflon-coated dishes than we do from vaccines. Aluminum, believe it or not, is one of the most plentiful common metal found in nature, including our bodies. And if you do happen to get an increase of aluminum and aluminum chloride, aluminum dioxide, your body secretes it quite quickly. Formaldehyde. And as many of you may know, formaldehyde was actually used as a preservative for milk for many centuries. And another interesting fact is we actually have formaldehyde in our bodies. And the amount in our bodies is about 135 to 180 micrograms per liter, which is far greater than the 35 to 100 that's left over from these steps. And indeed, the old school influenza vaccine was made from live egg-produced virus and then deactivated with formaldehyde prior to purification. So there was less than 3 to 5 micrograms per liter of formaldehyde even in that vaccine. There are other ingredients, antibiotics, which we're trending away from, thank goodness. And quite frankly, I believe there was probably more harm done with the antibiotics in vaccines than anything else, even though when the anti-vaxxers kind of stay away from this. There are also additives like gelatin, albumin, sucrose, lactulose, MSG, and glycine. There's nothing been shown with any of these to be associated with neurologic illness or autoimmune illnesses. There's also this you can obtain from the FDA, and it contains a list of the ingredients. I have found in my practice at the Center Against Sexual and Family Violence, where I'm vaccinating many children, the moms and sometimes dads who suffer violence, I show them this list, and the fact that they know we're looking is sometimes reassuring. Again, many references. People will often tell you it's not vaccines that made things go down, it's better living, it's better cleanliness. For those of us old enough to remember polio, yes, I remember being lined up and getting the sugar cube. Polio was actually a disease of the modern era. We were exposed to polio because of the filth that was often dumped into the streets, and we were exposed less than a year of age, where it's a gastroenteritis. You get exposed later and you get frank poliomyelitis. So it was actually modern hygienic practices that made poliomyelitis a dangerous disease, or a more dangerous disease. And yes, better living conditions have helped increase survivability. And hopefully we won't see a recurrence of the 1918 influenza because we've had increase. However, if you look at different vaccines, the Haemophilus influenza, and for those of us who were practicing medicine prior to 1987, I think we're all grateful that we don't see Hib meningitis or myocarditis anymore. We also have varicella, the chicken pox. I grew up in a typical Latino neighborhood where if a kid got chicken pox or measles, there was a party. We often don't remember the data that 90 children a year died from varicella. One death is too many. We also know that when countries like the United Kingdom, Sweden, Japan, and Italy abruptly stopped their using DPT, they saw a dramatic increase, which tells us two things. One, the vaccines were working, and two, there's a subclinical smoldering reservoir of all of these diseases. And this is data to show exactly that. This is looking at the laboratory-confirmed pertussis by age group in England and Wales. The sharp uptick is literally months after the vaccines were stopped. Yes, there is a waning of the vaccine in early adolescence and teenage years, which is why, again, we should revaccinate. Again, looking now at pertussis incidence in Spain, we're seeing similar data. In Sweden, we saw that an increase. Norway actually introduced the vaccine and showed a decrease. It's a perfect control group. Okay, hard to see, but what this data shows is that when the pertussis vaccine was introduced in the late 1940s or 1950s, we saw a dramatic decrease in pertussis incidence. Here's measles. When it was licensed actually in the late 1960s, we saw a precipitous drop. What people have forgotten is measles is a fatal illness. And for those of us old enough to remember it, it causes a pneumonitis, and children literally cough, have hemoptysis. Invasive hemoptysis influenza. The kids would come in tripoding, tongue sticking out, and drooling. The rule of the day was don't touch them until we can get anesthesia there. There's a myth, vaccines aren't effective. And I've had arguments with anti-vaxxers. In fact, I've had to change my Facebook site. I don't mean to be facetious, but there was a group out of East Texas that was actually frightened me. Apparently my vaccines were hurting children and that I shouldn't call myself a pediatrician. And as a result, there. I also had patients showing up in a free clinic that I work in Socorro in El Paso saying similar issues. They will confront us with our own data saying the experts say the vaccines are not 100% effective. I would never tell you, even the vaccine I've worked with is not 100% effective. There are people who have various responses to any given antigen. So we shouldn't say that. But they use that against us. Now, the vaccines are effective, and we also have a concept called herd immunity, which sometimes is difficult for non-scientists, non-physicians to understand. But again, they use our own words against us. Well, why isn't it going forward? Okay, you make it go. Okay. The pneumococcal disease is a good example. People hear the word pneumonia. Now, to us as physicians, the first thought in your mind is viral versus bacterial. If it's viral, is it adenovirus, influenza, RSV, human metapneumovirus? If it's bacterial, is it Staph aureus? Is it pneumococcal? So when you give a vaccine and you say this is anti-pneumonia, and a couple of weeks later the kid gets bronchiolitis, you might have lost that parent because that kid got viral pneumonia. Yet, importantly, the current vaccines we have against pneumonia are at least 70% effective in preventing disease and about 95% effective in preventing morbidity and mortality. Another point we need to tell our patients. You may get the disease, but it will be ameliorated by the immune system. Now, in vaccines, they'll tell you influenza vaccines aren't effective, and I wrote a paper back in 2012 about this. And part of it had to do with the characteristics of the person being vaccinated, their age, their health, what medicines they're taking. We discovered people who eat lots of barbecued food and smoke cigarettes have a lower response to the influenza vaccine. Why? I don't know, but an interesting association. Also, with the old school vaccine, I'm being a little pompous, based on the hemagglutinin antigen, it depends on which one's picked. And there's work that I've done looking at the Fujian Panama back in 1985, where Panama was chosen. Fujian strain emerged. It was only 15% antigenically similar. So that was essentially a vaccine failure. The other incident, I did a study with my PhD mentor, Dr. Edwin Kilburn. People think they got the flu from the vaccine. And we discovered there were a lot of interesting things going on. They were either got infected while they were waiting to get the vaccine, waiting in the waiting room, or they picked up another virus that wasn't influenza. So again, us as healthcare providers need to be very specific about what the vaccine covers. Okay. Guillain-Barré, which came out, as we remember, for the anti-influenza studies done under the Ford administration. And this actually, there were several studies, these are the meta-analyses, that actually showed no real relationship. And that if you look at vaccinated and unvaccinated, that the unvaccinated who got the disease actually had a higher rate. And they often also go on to say it hasn't been approved that way. The second vaccine that got implicated was HPV, a vaccine that prevents cancer in women. Thank God we're also giving it to boys now. There's been a 74% decrease in incidence of HPV, the cancer-causing strains. There is a belief that if you give the HPV, the children will become promiscuous. How about don't tell them what the vaccine's about? They said it causes serious side effects. And indeed, there were 3 young women who received the vaccine who had syncopal-like episodes, one of which required resuscitation for a bradycardial event. They turned out later to be unrelated to the vaccine. They both had viral illnesses, and the one with the syncopal episode also had orthopnea and was probably mostly dehydrated. They said they can give you the viruses, since they do contain oncogenes, can give you the cancer. Both of the HPV vaccines, the one we use here and the one in Europe, are made recombinantly either in yeast or baculovirus, and they only contain the antigens. I have to stop. Thank you.
Thank you, Doctor. So we're going to have questions at the end because we want to get to our other speakers, and thank you very much. I want to start with Dr. Gloria Wilder. Dr. Gloria A. Wilder, MD, MPH, is a nationally recognized pediatrician, entrepreneur, and public speaker, and an expert on poverty and social justice. She was formerly served as the chair of the Mobile Health Program at Georgetown University and the Children's National Medical Center in Washington. Dr. Wilder joined the leadership of the United Medical Center, becoming the Executive Vice President of Physician Integration and Strategic Alliances. Dr. Wilder used her business entrepreneur to found Core Health, a wellness company dedicated to assisting underserved communities in improving access to quality holistic health care. Through Core Health and Wellness Center in Washington, Dr. Wilder and her team have provided comprehensive primary preventive care and alternative health services in beautiful state of medical home. In 2007, Dr. Wilder was selected by Michael Detroff, the CEO of Centene Corporation, to be one of the founding members of the Centene Health Advisory Council, where she continues to serve today. Dr. Wilder has received multiple awards, and you have her bio, and I don't want to take the time that you need to meet her and hear from her. For this, I have had the pleasure of sitting down and having a one-on-one with her that we thought we'd sit down for 10 minutes. We were together for about an hour and a half. It was quite an interesting experience. So I'd like you to have the same one. Dr. Wilder.
Thank you. Good morning, everybody. All right, come on, good morning. I'm so happy to be able to join you guys here this morning. I'm here partially in my role as Vice President of Innovation and Health Transformation at Centene Corporation, and partially in my role as CEO of Core Health and Wellness Centers, and really in my role as street doctor, okay? I'm a practicing pediatrician, always have been, and this is my 25th year in practice, and I've called myself a street doctor because I've always taken care of kids who either were homeless or vulnerable to be homeless. And this new thing that everybody's talking about now, the social determinants of health, have you heard this thing? It's brand new. Oh, we just discovered it. It's like a new flu vaccine, right? So this new issue of acknowledging that the environment in which you grow up, are raised, or have to exist actually impacts your life and your health. It's just amazing to all of us in healthcare, isn't it? So the opportunity that exists now that the country is once again reawakening to the key issue, which is, does health matter, right? And if health matters, right, how do you measure the input of health care to health, right? I mean, it's a basic question, but when it comes to those of us who are focusing around these innovation models, we know healthcare innovation, honestly, right now, we're probably at the most exciting time in healthcare innovation, and we've been at since the discovery of penicillin, right? Where innovation is happening every single day, everywhere, in every division, every single field in medicine is innovating like crazy. The genetic code, I started my career as genetic counselor at Georgetown, and we used to dream of having the genetic code cracked, right? Not only is it cracked, but you can like swab yourself in the bathroom and in 15 minutes know if you're related to the person sitting next to you. So it's an amazing time. But as we look at these types of innovations that are scientific innovations, as we look at personalized medicine, as we look at innovations in technology in healthcare, we also have to look at innovations in systems, process, workforce, right? How do we actually start to move our country from paying for a service, right, which is what healthcare has become in the U.S. It has become very focused on outputs. How fast can you see the patient? How many can you see in a day, right? How many screens? How many shots can you give in a certain amount of time? We're so focused on outputs that what has resulted is that we've seen the outcomes of health care don't actually get us towards health. Okay, we're going to think about that one for a minute, right? The output is there, we're doing a lot of activity, but our nation is sick and getting sicker. And we have a nation where we pay for disease, right? And in fact, our entire payment models are structured around disease. And we even have terms that we've accepted now that would have outraged some of us who trained, earlier in the decades. Terms like disease maintenance. I did not go to medical school to maintain disease. I did not. But it's become an acceptable term in all of the industries of health, right? Chronic disease management. Does that bother anybody but me? Right? I actually want to cure disease, reverse disease, right? And go back to primary and secondary prevention. Y'all remember those things? Okay. Because when we talk about innovation in healthcare, right? I want you to just know, and I invite you to join us at Centene and all of the providers across the country, right? And all of the systems folks across the country who are really taking a good hard look at why did we miss the mark? Why is our country getting sicker, right? Why do we have a greater disease burden? And why have we accepted disease as a normality for a certain percentage of our country? There was a really scary survey of young folks, and young folks, look, I'll tell you, this will show how old I am. Young folks being 30-year-olds.
Yeah.
Okay. That where they started to talk about in terms of the healthcare system, right? Their engagement with the healthcare system was aligned with their expectation of getting a disease. So their engagement with the healthcare system was not about staying, vibrant and strong and setting goals for their life and achieving, what their ultimate dreams are. It was when I get hit by a car, fall off a bridge, right? Or get diabetes or hypertension, then I will expect to engage with the healthcare system. That's a dangerous precedent. And one that, again, is a difference in generations. Generations before expected the healthcare system to actually keep them healthy, right? Make them healthy as a senior, and they could, be able to be mobile, and they would talk about mobility and things like that. But now this new generation is talking about disease and how the healthcare system will help them with their disease. Why don't we decide that that's not acceptable? And so when we start to decide that, what we have to look at are what are the system structures that are in place that's causing this to happen. And I think you all can probably, yell out a bunch of them. But let me go through some that we're particularly concerned about. One is how we pay for things, right? Right. We have a coding system that is so heavily weighted on the disease process that when you have a patient, and I'm a little biased because I'm a pediatrician, right? So all the pediatricians in the room know that most of the babies start out just fine. Yeah. Okay. Even the ones who have a little challenge, right? Come on, we spuff them up and they do just fine, right? And so we give a good, healthy baby, and we put that baby into the environment, right? And you guys screw them up, all right? Like they come to us every couple of months, we're going good, right? And then somewhere around 5 years old is when we start to deal with things like childhood obesity and other impacts of the environment, right? But the sad thing is, the moment that something starts to go wrong is when the system actually starts to pay more money, right? We don't pay a lot of money when everything's going right. When it's going right, we say, oh, come back in a year. We'll wait for something to go wrong. But then when we find something wrong, we can see people more often. And do you notice that even in pediatrics, when you get from 5, we don't really have to see you again until you're about 10. And in some states, right, if there's not a vaccine to be given, right, some folks feel like, why do you come in? Right? So there's this huge gap where we're waiting for something to go wrong. Right? And as soon as it does, we can start charging and seeing and giving information. But we can't pay for things like gym membership or healthy foods or quality housing while your life is going okay, right? And we have to start looking at what are the things that actually contribute to a well life. Well, there are 5, right? Let me give you the cheat sheet on this, right? There's 5 keys. Whether you want to call it social justice, whether you want to call it quality of life, these are the 5 things. You need access to quality health care, right? You need access. But remember, access doesn't get you health. It just gives you access to a service. So you need access to quality health care. You need access to a quality education. I think we all know this. Everybody in this room has had access to a quality education. And for each one of us who sat in any college class anywhere in the world, there were 2,500 other people equally as qualified for that seat and did not get the opportunity. And then we wonder why the numbers are what they are, right? Still in the U.S., right, you cannot get even community college education for free. But it really is necessary to live a healthy life ultimately. Okay, so that's the second thing, is quality education. The third is economic equity, right? Or economic justice, whatever you're comfortable with, okay? Right? What it means is you have to be able to earn a living wage, right? The minimum wage in the United States is a poverty wage. It always has been, and it continues to be. The formula for the minimum wage was written in 1964, right? And it was based on the fact that at that time, the heaviest expense a family had each month was food, was the cost of food. Currently, the heaviest expense a family has each month is, somebody yell it out, housing. Exactly. Anybody here from New York? Right. The New Yorkers should have screamed, housing! Right? Same thing in California, right? Right? Who's trying to live in San Francisco? Not I, said the cat. Housing. So if the formula still weights food as the heaviest expense, and housing really is the heaviest expense, are we surprised, right, that people who meet the federal poverty guideline and then get a minimum wage when they work, right, end up working 40 hours a week, but still being in poverty? Right? So the minimum wage is a false wage. It is actually the minimum you need to stay poor, working full time. Okay, so we have to advocate for a living wage. The fourth key is environmental equity or environmental justice. What does this mean? We know what it means. We know of lead in Detroit, but lead has always been in the waters of major municipalities across the country, right? We know that certain public housing in this country was intentionally built on brownfields that keep people sick, right? You're on top of a garbage dump. All right, so how do you expect that you're not going to have high asthma rates? And we know the asthma rates in public housing versus private housing. This is not surprising to any of us, right? Environmental justice. The other piece of environmental justice that's really critical is community violence. You cannot be healthy and live in a violent community where you're constantly ducking and wondering, am I next? Is this going to happen? Where people in your family are being captured and taken places where you don't know. That's not health. That level of stress on a community is not healthy. And then the fifth key is something I think we think about all the time, but it's both civil and criminal justice, right? So legal. We already have a public defender's office for criminal justice, but I want to talk, and we know the numbers, right, in terms of mass incarceration, especially Black and Hispanic. Like, let's talk about it. 2.1 million folks in prison right now. Like, for real? No. How do we have more people in our prisons than both China and like Iran? Like, really, we're incarcerating by percentage more people than countries who we always thought were outrageous. And we have for decades now. So mass incarceration is a huge issue. Structural racism continues to be a huge issue in our nation, and it impacts health and health outcomes, right? But the other one is on the civil side, right? No representation in civil court for people who are poor, right? So your Medicaid patient who keeps getting evicted from certain housing because they have a child who has attention deficit disorder or is hyperactive or talks too loud or bangs on the roof or whatever, has no representation when they go into civil court to keep their apartment, to keep their place. And in some states or cities where housing is so restricted, getting evicted means that you will never be housed again for a significant period of time unless you get it under somebody else's name. So those are the keys. In terms of how we take that and we start moving this ball on innovation, we are encouraging everybody to work together collectively with us and others, right, to look at what we're paying for and know that in healthcare, with healthcare being 18.3% or so of the GNP, there's no shortage of dollars. We just have to redirect dollars. And we all have to start being honest, right, about what we're billing for, right? And did it matter? And when you say, did it matter, the question that we will continue to ask is to whom? Because we think that, yes, it has to matter to the state. Yes, it has to matter to the provider. But it has to matter most to the patient. The patient has to have some say in what they think is a valuable health outcome for themselves versus a healthcare service that we say you need, right? You need this service, but does that service matter to you? Does it help you reach the goal you need for your family? Or should we take certain dollars and help you to complete your education, to get better housing, to get quality food? All of that to us is innovation, and we invite you to join the conversation. Thank you so much.
Thank you, Dr. Wilder. What I'm going to do is hold the conversation and questions till the very end, so we'll get all the speakers up and doing their presentation. Thank you again. So, Yolanda Robles is the president and founder of Cultura. She's been instrumental in helping healthcare organizations improve the delivery of services to multilingual and multicultural communities. So what we're doing now is transitioning to what we need to do, to how we need to do it, and what the resources are for us. Yolanda was born in the Dominican Republic and immigrated to the United States when she was a child. She is now a member of the Joint Commission Long-Term Care Advisory Council, the American Hospital Association, the Institute for Diversity in Healthcare Management, and trained as a consultant in the American Medical Association for Ethical Force Programs Communications. I will not spend too much time. You have her bio again. I would like to give her the podium. Welcome, Ms. Robles.
Thank you so very much. I don't know if I'll be able to surpass the wonderful conversation that Dr. Wilder had today, but I hope that I can contribute to it. Ms. mentioned, my name is Yolanda Robles, and my company is Cultura, and we work with healthcare organizations to help them improve outcomes for diverse patient populations. That's really important today because, as we know it, disease states are so prevalent, particularly among individuals and people of color. Disparities exist significantly. So what are some of the things that can be done by healthcare systems to improve the processes and practices that are being laid out today? One of the things we know very clearly is, according to the consulting firm Deloitte and Touche, they basically mentioned that by the year 2040, healthcare systems and the healthcare organizations as we know it will no longer exist. The healthcare organizations that will exist are those that are going to embrace change, that are going to embrace wellness and be able to manage the patient populations that are out there today. So healthcare organizations need to have data to be able to do this. So how can data really make a change in the way healthcare is being delivered today? Well, as many of you have heard in the past, data drives decisions, right? If there is a decision that needs to be made as a physician or a researcher, you know that it's important for you to have the information because you're not going to prescribe a patient something until you diagnose them. So the same thing with healthcare organizations. We need to make sure that the data is there. And not only is it important to have the data, but to be able to use the data to make informed decisions and not just base the decisions that you're making on observations. So no matter how much data we have, if we don't use the data and act on it, then you cannot have any kind of innovation that will exist today. So I'm going to share with you a case study of an organization that I worked with and that showed how they leveraged data to be able to really bring forth change, particularly with the Hispanic Latino community that they were seeing within their communities and their healthcare systems. The importance of this case study is not only that they actually received data and gathered data, but that they actually converted the data into actionable items that brought forth some innovation for them. It might not be innovation for everybody, but at least it made an impact for this organization and improved the experience of the patient. So one thing I want to share with you is that this client that I have is a large healthcare system, and they basically have about 100 plus hospitals across the country. And one of the things that they realized was that the Hispanic population was not coming to their organization, or if they were coming to their organization, they were not staying. Why? Why was the reason? So they went on and embarked on an enterprise scan. And so the enterprise scan that they embarked on created some data points that were very important to them. They realized, and they kind of knew, but they realized from the data that the Hispanic Latino population was an emerging market, one that they were not capturing, and that the future, because of the fact that by the year 2040, 2050, there was not going to be a majority, but it was going to be, a majority minority. How are they going to engage these patient populations? They also realized that there was a significant difference in the way they were thinking about the Hispanic population. They were thinking, oh, these individuals are going to come in and they're going to redline my bottom line. There's going to be a lot of charity care that I'm going to have to give. But then all of a sudden, the data showed them that this population now is a lot more affluent than it used to be in the past. Not only are they more affluent, but now they have a lot of access to be able to gain information and to be able to gain insurance. And if they actually capture this patient population, what was going to happen then is that they were going to be able to keep them longer because of the loyalty of the Latino patient. As you know, you come in and you have your baby, and if this organization is really good to you, then you're going to make sure that well baby care is there, and the peds business is going to come to the organization. So they realized they needed to do something. They needed to be able to really innovate in order for them to bring forth a difference and really create a situation where the patients were going to feel comfortable and were also going to be able to get the services that they needed. It's important that they needed to really look at changing the processes that they had within their healthcare system, because these populations were not going to really work within the process that they had. As a result of this, they realized, oh my goodness, not only am I not seeing these populations, but I really have a problem, because in the major markets that are traditional Hispanic markets like Florida, Southern California, Las Vegas, they were so under-indexed in those populations that they knew that it was not only the fact that the organization was losing revenue, but that the populations were not being served appropriately. So what did we do? We worked with them to establish and create a cultural and linguistic navigator program. Navigation is something, of course, that has existed for a while. It was created to be able to reduce disparities in healthcare. And in today, you have promotoras de salud that are out in the communities. You have community health workers. The difference was what they wanted to do was they wanted to navigate the patients from inside their healthcare system back into the communities. And the reason was because the Latino population was coming into the emergency department and using it like primary care. So that was a significant cost to the organization. So how do we manage that? So they hired a bilingual individual, trained this individual how to become a navigator, and so this individual was able to take the patients, understand their challenges, bust their barriers, and get them into the care that they needed in order to reduce what they called leakage, meaning I want to be able to keep that patient within my healthcare system. So they wanted to be able to increase the cultural competence of the workforce, increase the Hispanic patient volume, and capture that Hispanic patient loyalty across the board. So the Navigator program was established as a result of the data with the overall goal to develop a strategy to better align the services to meet the needs of the Hispanic consumers. And so as they gathered that data and created this program, they also realized that there was a lot of other things that needed to be improved within the organization. Putting the Navigator in there was not just enough. They really needed to show their commitment to the Latino population, create this welcoming environment for them, and be able to establish a process and a program that was going to be beneficial for everybody. So the program results were very, very great for the organization, and they really started to understand the Hispanic patient. So one of the things the Navigator did was in making sure that the patient, when they left the hospital, they were actually already had an appointment with a physician. And so in the beginning, only 20% of those patients that were leaving were able to get into their appointments. After the navigation program, it went up to 72%, which was pretty significant. All of a sudden, they saw more Latino patients coming to them because of word of mouth. As you know, how we'd like to tell others what great things are out there or what bad things are out there. The Hispanic population started to grow. Then the Latino patients actually stayed within the healthcare system because they would always call the Navigator for information. Can you help me know where to go? And of course, the Navigator made sure they stayed within that healthcare system and also connected them to community services that were very, very needed. So it really resulted in a huge improvement in the way services were being delivered in that healthcare system. One thing I do want to share with you as a result is not only did they do that, but they improved the collection of real data, race, ethnicity, and primary language. Patients were coming in and they were not knowing even that they spoke Spanish. So they were not providing interpreter services for the patients. They did not have vital documents translated into the languages that were appropriate. And they also had a real challenge in the handoff between the Hispanic patient and the next level of care that they were supposed to be in. So all of these things were improved. So the data that we capture today and how we use the data is really going to be a value to not only the organization, but to the patient. So what I like to do is close by sharing a patient story. This is an actual patient that came into the ER and the situation that they were in. So this patient had multiple return visits to the ER, averaging 2 to 4 visits per month since they started coming. Every time the patient would feel ill, her immediate choice was to come to the emergency department. On her last visit to the hospital, the Navigator was able to guide the patient post-discharge to appropriate specialties under health system umbrella, as well as provide guidance to community resources the patient would benefit from. The patient, Mrs. Garcia, established care with her primary care doctor and specialty providers as a result of the navigation program. Mrs. Garcia was set up to receive personal care assistance services as well as social services such as Meals on Wheels program that was so needed. Since her last visits, Mrs. Garcia has been able to maintain a stability with her health and has been educated on the importance of keeping her appointments and her providers. She was closed from active navigation but continues to call the Navigator for assistance in scheduling her appointments. So that really brought a lot of goodwill to the community, and the experiences of Mrs. Garcia are the type of experiences that we want all of our patients to have across all healthcare systems. So using data to innovate, extremely important that you really truly understand who your communities are, what issues are they facing, how are you going to be able to help them by not just guessing, but by truly getting the information that you need. And at the end of the day, it's all about how can we continue to improve culturally competent, patient-centered care. Thank you.
Thank you so much. So we're actually on time, which is great. So we've learned, we've established and renewed some of our clinical knowledge base. We've learned what we want to do and what we should do. We've learned how to measure what we're doing and analyze this. And now we're going to move on to how do we market this? How do we spread it? How do we make it actionable and make it available to the patients we serve and to the physicians? So Mr. Jose Aguilar is a Mexican native, and is a global marketing and commercial executive with extensive global experience conducting businesses more than about 60 countries. He started his professional work at the Gallup organization conducting market research for multiple clients in Latin America and the United States. After completing his MBA at Emory, Mr. Aguilar had led on a global basis, was well recognized for branding both the consumer and over-the-counter markets for the Fortune 500 companies such as General Mills, Bausch & Lomb, and Abbott. In this capacity, he has drafted global strategies, campaigns to support current and new product launches for medical, HCP, market, and consumer markets. And we would like to hear how he's doing today. Mr. Robles.
Buenos días. Well, I want to thank you to the National Hispanic Medical Association for the invitation and join the conversation that Dr. Wilder alluded to about how to use technology, innovation, to provide access to care to all individuals around the world. I am Jose Aguilar. I'm the Chief Strategy Officer of OI Health. And what we are, and we have the mission, is to provide access, and we have the passion as well, to provide access to quality primary care and affordable primary care to all underserved populations and access to low-cost medication through the use of technology and without the need of a third-party insurance company. And I'm going to explain how we do that. In addition, we are very particular about underserved populations. As you know, underserved medical communities struggle with access to care. They are lumped together with the general population. They don't distinguish between cultural and language barriers, and they struggle because of that reasons. I'll show you some statistics about how these organizations, these communities struggle. I'll show you some Hispanic statistics. But there are opportunities by the use of technology that will help solve these type of situations. And I'll finalize with how OI Health is using this technology to provide that access. So let's review the statistics first. As you know, and we were talking before, the rate of insurance is increasing. However, still 16% of Hispanic population is uninsured. That's double the rate of the non-Hispanics, which is about 6 to 7%. So even though it has improved throughout the years, there's still a significant way to go. Other interesting facts, probably all of you know, 19% of the U.S. population is Hispanic. We're going to be 30% by 2050. 1 in 5 children are now Hispanic. However, only between the two of you, all of you, 5 to 7% of doctors are of Hispanic descent. And always argue that many doctors probably don't speak Spanish to treat patients in Spanish. So there's also a significant opportunity to reduce that gap. 33% of those Hispanics don't speak English well enough to access care. One of the major barriers that you listen from a Hispanic patient is they don't speak my language. A fourth of Hispanics don't have a primary health care provider. They don't have insurance, they don't have a provider, they don't speak the language. So you can see that the barriers to access to care are accumulating with all these statistics. Final one, 20% of Hispanics live on the poverty line. They cannot afford their medications, they cannot afford their primary care needs. The consequences of all these are significant. We were talking about innovation and access to care and how we can not only maintain and manage chronic conditions, is we need to solve how we can provide access to those communities that struggle with no insurance, with no language capabilities, with no income to support families. As you know, 1 in 5 diabetics in the US is Hispanic. Interesting fact, half of Hispanic children born after 2000 will develop diabetes. 50% of Hispanics will develop diabetes. That's we as Hispanics are twice as likely to develop diabetes than non-Hispanics, and how we can provide access to care. Finally, we tend to be diagnosed very late. Probably it's also cultural. We don't go to the doctor that often. It's part of our culture not to go to the doctor. So we are diagnosed very late. And of course, as a result, the treatment is much more severe to help with that diabetes. But everything starts, again, with that access to care. Technology today has proven to be useful in helping those populations around the world. Why? Because digital health and digital usage aligns very well with Hispanic usage. Let me give you some statistics. 84% of Hispanics are online. That's a bit higher than the national average in the United States. We use smartphone internet 10.5 hours a week. So, and as you know, most of us are in Facebook, talking to our parents in our home countries, talking to our families in other states. We use technology, the smartphone, significantly. That 10.5 hours a week is 25% more than the national average. So the question then is, how can we use technology? How can you use the smartphone to provide access to that care? And that's who we are. OI Health is affordable and accessible primary care and the medications needed for that primary care for everyone without the need for insurance. Again, because even though 16% don't have insurance, still is double the rate of the non-Hispanics. At OI Health, we have a platform, an ecosystem of 5 distinct products that provide access to medication, to chronic condition management, and I love the phrase of Dr. Wilder. Management is, we want to improve the condition. We don't just to manage the condition, we want to improve the condition. Now, we'll think about how to change the word management for the future. It's very important. But we want to improve, health and wellness. And we also found some products for patients who don't have insurance and have diabetic or hypertension needs. And I'll go through each of those. Let's start with OI-RX. The ones on blue, and I think I can point there, but anyway, the ones on blue are medication access through the use of technology. One is called OI-RX, the other one is called OI-Meds. OI-RX is a platform, oirx.com, where we standardize the prices of all generics across the country for 3,500 generics for primary care. So today, if you go to CVS, the price of one generic is one price. If you go to Walgreens, it's another price. If you're in California, it's another price. If you're in Alaska, it's another price. We standardize the prices of all these generics because for low-income consumers, the most important factor in a monthly expense is cash flow, cash management. So if I know that I need to spend $10 every month for my metformin, I will go and buy and spend $10 every month. Cash management and cash control is fundamental for low-income populations. So you go to our website, you purchase a medication, pre-purchase a medication, the system generates a voucher, and with that voucher and your prescription, you go to any pharmacy in the country to pick up your medication. Because we standardize those prices, now you can gift medication. All of us have families all over the country, all over the world. I can now buy the medication for my mom in California, and this voucher is sent to her, and she goes to California to pick up her diabetic medication. Or my mom is in Mexico. Instead of sending money through MoneyGram or Western Union, I purchase the medication in oirx.com, and my affiliated pharmacy in Mexico delivers the medication at home in 24 hours. So we're trying to partner with all these 5 products, with institutions, with primary care facilities, to offer all those products to your patients. The second product, OI-Meds, is a prescription discount savings card. That works, and that's available in many forms today, but you register to receive the card, which is for free to register, and then the system directs you to where the cheapest discount is in your zip code. So I live in New York City, I type my zip code, and I need metformin. It will tell me that Pharmacy X has the cheapest discount with this discount card. So we try to direct consumers to the cheapest location for their medications. Now, in this instance, the medication prices and discounts vary by location, by chain. So the difference between OIMED and RX is that in one, we standardize prices on generics. In OIMED, we direct consumers to the cheapest option, and they can go there. In OIMED, all the branded medications are also included, so that's also a benefit for those patients who need a branded medication, and the doctor prescribes a branded medication. OI chronic condition management, improvement, let's call it now, chronic condition management. What we do here is we partner with hospitals and we tell them, hey, and we have spoken, and I was in some of the sessions yesterday, all low-income population, uninsured populations go to the ER for the primary care needs. Hospitals don't like that, as you know. You know, they lose significant amount of money. The cost for the healthcare system is significant. So what we say is, why don't we manage that patient who is chronic remotely for you from home? In addition, because now I can monitor that patient in the community, we have been discussing the social determinants of health. We can address how that patient lives in the community and try to help that patient to improve their condition. In this case, we provide all the devices and peripherals to the patient. Those are sent to home. We monitor the patient on a regular basis, on a daily basis, and we follow the protocols of the hospital. So if the patient is within certain ranges of the protocol, that patient never goes back to the hospital. If something happens, we follow the protocol and we send the patient to the ER or to a special assistance. They have access to peer support. One of the big issues in chronic conditions is peer mentoring. What happens today in hospitals is that they'll tell you, oh, there's a group support on Friday at 3. Well, I need to leave my kids with my family, I need to take a subway for 2 hours, and I need to leave my job. We provide the peer mentoring on a virtual basis, and what we have seen, for example, is that people call at 10:30 at night. When the day is over, when the kids are sleeping, I call my peer mentor and talk with that person. And we link the patient demographically with a peer mentor. If a patient is a mom from Mexico with 3 kids, 50 years of age, we link her with a patient with the same characteristics. So there's also this emotional connection. And we reduce the cost for the hospital significant. In a sense, we move a patient who is the most costly for the hospital to one of the most profitable patients for the hospital. And finally, Oil Life. Oil Life is a kit, a retail kit that patients can buy. When we partner with several hospital systems that they don't have insurance, what the hospital gives them is an all-in-one kit for all your needs, and we're starting with diabetes and hypertension. We're continuing to add more conditions, but it's an all-in-one kit for all your medical needs, and it has the test strips, the lancets that you need for daily monitoring. And because it's an all-in-one bundle package, the cost to the patient reduces significantly versus buying each piece independently. And we have a telemedicine in bilingual, as we discussed at the beginning. The challenge is doctors in Spanish. We have a telemedicine that we can provide to all of you for you to provide access to patients on a bilingual basis or just in English. And it's sporadic, it's not a subscription, and they use it when they need it. But important of all these products is a direct cash pay solution. We want to address the needs of uninsured populations, the need for underserved populations, that they don't have the access. We lower the cost. They pay, in some instances, the hospital pays. We have some hospitals, for example, that they say, paying the medicine for my patient is less expensive than the readmission cost. So I'll pay the medicine for my patient, and I'll reduce my readmission cost, something that we can discuss. And there's incredible opportunities to give medication to your family members who struggle with income, who struggle with conditions through our program. But today, with OI Health, we believe that technology can be used for good to provide access to those populations who need it the most. And I'd love to discuss with you how we can do that with your organizations. Thank you very much.
Well, we have actually about 15, thank you all to the speakers, and thank you so much for keeping on time. You were perfect. We have about 15 minutes to, actually more, 16 minutes to ask questions and to discuss.
Hi.
Introduce
My name is Luis
give your name.
Alzate Duque. I'm from Rutgers, New Jersey Medical School, and I wanted to ask a question for Dr. Johannson, Dr. Bert. I wonder if acknowledging our past mistakes can help us kind of deal with the problem of vaccinations. As a med-peds trained physician, and by that I mean this, in 1992, Wakefield et al. Was published in Lancet, which attempted to show a link between MMR vaccination and autism.
Yeah.
Within a year, 10 of the 12 authors in the study retracted their findings. And in 2010, so almost 20 years later, Lancet retracted the study.
Yes.
Because of violations, ethical violations, and lack of financial disclosures.
And they couldn't produce the data.
Exactly. So I wanted to know if you can speak on acknowledging that fact to our patients to kind of let them know that we made a mistake, but this is what we found since.
Yeah, and I agree with you. And I think the forum, and this is a wonderful question, it needs to start with us as physicians and nurse practitioners. When you think about some of the errors, and they go on, Ted Hoffman from California with the biosynthetic drugs, John Mercola, who apparently can detoxify your blood after being given the DDAP vaccine, also Wakefield, who, by the way, had his MD stripped from his medical school. They took it away from him. So we need to bring this out. Be prepared to be confronted from a patient who goes, that's just because Big Pharma is trying to squash them. And you have to learn to pick who you can talk to and who you can't. But in the same token, we need to look at Fulginetti et al. 1969, which was an attempt to produce an RSV vaccine, which actually made the disease worse. So just as we need to confront the Mercolas and the Wakefields of the world, we also need amongst ourselves to say, hey, look, we screwed up. We need to move forward. So you're absolutely right, but I think we need to start here first. Great question.
Next question.
Hi, I'm Daniel Corian, a pediatrician from the Bronx, and I would like to comment on what I would call 3 inconvenient truths. The one is about the academic medical centers. Academic and medical centers and big hospitals have around them one of the worst health statistics in the country.
Yes.
And that has been going on for ages. I would believe changes in those institutions, when I see hospitals and academic medical centers dealing with housing in the community, education in the community, and jobs in the community. Until that time is something that I don't believe, because we have been there a number of times. Regarding the navigators is something that I feel I have worked a lot with navigators, and one of the stumbling blocks is that they end up being co-opted by the organization. It's bringing patients in, but they don't allow them the most valuable teaching for the institution, which is really, what does it mean to be a diabetic in the South Bronx? Or what is it that the contextual knowledge of the community can inform those individuals? Lastly,
Can we comment on that one before you move to your next one? Because I think that's a very important point you're making, and it's what we talk about in our study when we talk about systems innovation. The truth is, living within 5 miles of an academic institution or a large hospital system in the United States and being low to middle income or in poverty is one of the worst health choices you can make, right? Because of exactly what you said. The economic drivers favors their faculty and their students over the residents of that community, right? And we've seen it time and time again in our country, and we refuse to talk about it as physicians, but we must. So I think you make a very, very good point, right? And we all, we've all been educated in academic institutions across this country. And I'll just say real quick, my brother, Craig Stephen Wilder, is chair of history at MIT and wrote a book, Ebony and Ivy, and it talked about the impact of slave dollars in building the academic institutions across this country. And because of that book, Georgetown, right, yesterday, right, the students voted to give reparations to the 272 slave descendants of Georgetown. But Columbia University, Harvard University, Yale University, Stanford have all apologized, right? We need more than apology, right? We need systems to start to change.
Mm-hmm. I'd like to...
Yes, and then
No.
They all want to answer you. Okay.
I guess there we go.
Then we have to move to the next question.
I think as a company, we're advocates of use of technology. I think institutions like academic medical institutions, what they need is visibility in the community. And I think technology today allows that to happen. I can monitor, and of course, and I forgot to mention, of course, it's all HIPAA compliant and digital, but if we can monitor the patient on a daily basis from home, I think and we have the determinants of those conditions at home, in the community, lack of housing, lack of economic opportunities, and through this regular monitoring, not only from a health perspective, but from these other variables, I think institutions will benefit tremendously to reduce costs from.
About data, and I think that we have to be clear about data benefiting who? Exactly. Because I'm going to address one issue that is my topic of interest, which is Latino men's health and masculinities. And for example, when you have the invisibility of Latino men's health in terms of aggregated data, you look at the diabetes prevention programs is 70% females, 30% males, and you see it all along the health statistics. Thank you.
Thank you, Dr. Korn. Next question on this side.
Hi, good morning. My name is Diana Montoya Williams. I'm a pediatrician. I work in Philadelphia, but also do some work in Florida, including a free clinic for undocumented immigrants especially, and I'm very intrigued by the OI Health model and services. So I was wondering, are those services available to people with no documentation status? And if so, have you noticed differences in uptake, or are you trending that, or have you noticed any barriers in working with that particular community?
Yes, we address the immigrant population regardless of status. Actually, one of the challenges in the Hispanic population, as always, is because of that situation of legal status, and today in today's environment, we don't ask even your status. It's about your health, and that's what we care. And yes, we have seen uptake. Since 2 years ago, all the non-for-profit organizations have seen actually a decrease of people attending events and health fairs because of fears of being deported. It's coming back a little bit. So we are helping those organizations to attract more Hispanics to these events. And again, we don't ask for any status. We don't ask even for, when we send medications, we need to ask for the address, but we don't ask anything else, So yes, we have seen improvements in care in those populations. We are talking with several organizations, not in the US, but other parts, to use technology for refugees. Because eventually, everybody will have their electronic medical record in their smartphone. So if you are in Costa Rica, you have your electronic medical record. If you are in the US, you have your electronic medical record.
Good answers. Thank you. Next question.
Dr. Carlos Gutierrez from El Paso, Texas, private pediatrician for 39 years. First of all, a comment before I ask my questions. Dr. Wilder, you're a pediatrician after my own heart. Your talk is so inspirational. Your talk is a lot of the reason why I'm a pediatrician, and I hope that all of us can follow your lead and set your example. And Dr. Bert, just a quick question: how do I address my patients. I don't have many problems with people who don't want the vaccines. However, the few that do, that give me or that express their desire, no, I don't want this. They give me the excuse of they don't want vaccines that include aborted fetal cells, and that's a thing that most of the thing that I hear in my practice. But finally, and then I'll sit down to Yolanda, Ms. Robles. You mentioned about the navigator system. It seems like in El Paso, the navigator system seems to be us pediatricians, and if we don't do what the Medicaid people come and talk to us and say, you need to do this, you need to keep them out of the ER, you need to stop using this medicine and this and that, and if we don't do it, we get punished by not being reimbursed. We, instead of getting a little bonus at the end of the year, we get a less of a bonus. So we don't have any navigator. It's like we are the navigators. And I'll end at that.
Thank you.
And I'll just comment on that. One of the things that it was important for me as an individual, when I started Cultural Link, I had two options. One option was to really go out there and become an advocate for the patient populations that were not getting the treatment that they deserved or the access to care, or to work with healthcare systems to help them, the ones who really can change policy and that have the funding to be able to make a difference and bring forth change. So that's what I decided to do, and that internal healthcare navigation program is one of the different programs that can actually help them do that. So the healthcare systems are the ones who have to really put their money where their mouth is. If they want to improve outcomes for patients, they need to provide those programs to be able to do it, and it shouldn't fall on the individual practitioner.
Thank you. Question over here?
Can I answer, Dr.
Oh, I'm so sorry.
And
Next.
Dr. Gutierrez, thank you for that question. It's often brought up. And it's also,
Yes.
again, another mixing of what the anti-vaxxers do. The Sacred Consortium on Life from the Vatican actually has ruled on this.
Yes.
Part of the problem is us as physicians. We came out and we said that the vaccines for rubella were isolated from legally aborted fetuses. This was in 1963. What we really need to say is these children were already dead, and the cells were isolated from them. And the abortions were to save the mother's life, but again, the fetuses were not viable. The second component is people will also tell you that the measles vaccine is derived from fetal tissue. Dr. Harold Hillman isolated the Jenny Lynn strain from his daughter, Jenny Lynn, who lives today. So we're dealing with a little mythology and a little bit of our own inability to pick the right words. But again, the Sacred Consortium on Life, and it's available online at, believe it or not, Vatican.org, and you can read about this.
Thank you. Thank you. Next question.
Yes. My name is Jaime Estrada. I'm also a pediatrician.
Oh my God, we're all pediatricians.
It's why we like you, Jaime.
What's going on here?
And I recently retired after 35 years in practice as a pediatric oncologist in San Antonio, Texas. And now I'm leading a task force on HPV vaccination, working with the American Cancer Society.
HPV.
And you all know the benefits of this vaccine as a cancer preventive vaccine. And so I wanted to ask Dr. Johannson, how do they do it in San Antonio? Because your vaccination rates for HPV are so good, are the best in Texas. And we in Bert County in San Antonio are trying to emulate whatever you are doing. So tell me, what are you doing?
One of the great privileges I've had is I've worked in the South Bronx and northern Manhattan and then moved now to the border. And one of the things that I love about working on the border is our patients trust us. Claro que sí, doctor. And I think a lot of it has to do with the community and their trust with us. And where I'm doing, I'm volunteering in Socorro Barrio, one of the poorest neighborhoods in El Paso. And they love the fact that you're there. And I can also tell you, my own child went to see Dr. Gutierrez, and he's honest and upfront. And again, they established this relationship. So San Antonio has undergone a lot of changes in the last 15 years. And I think if San Antonio gets back to its roots and talk about some of the things that OA is doing and some of the things that Dr. Weiler's doing, those vaccination rates will come up. And it has to do with a face-to-face relationship with your patient.
Absolutely. Absolutely.
Oh, and congratulations, Dr. Robles, for an excellent panel.
I'm
Dr.
Flores.
Robles, congratulations for an excellent panel.
I'm also a pediatrician. I'm sort of hiding it, but I am.
Good morning. John Ramirez from Houston, Texas, first-year dental student. I just wanted to comment about your brother's book about ebony and ivory. I read a lot, so USA Today published that it would take 431 years for African Americans to accumulate the wealth that other populations have. So I'll definitely look at your brother's book. Mine is a three-part question for OI Health. First, is it a private company or is it publicly traded? Second is, do you guys provide any scholarships? Because I see a lot of companies that came here. When we talk about growing the Hispanic population, but it's only 5%. A lot of Latinos don't go, especially males. I think one of the doctors mentioned, a lot of women, which I'm proud of, Latinas are really going to school and they're changing the social economic background in the health field. So if you guys provide any scholarships. And then my third question, since I provide dentistry, where do you see, or are you guys doing any research for online dental treatment? I know at one point they tried to do a pilot, but it's very different because our services are more mechanically inclined to be in the patient's mouth. So mine was a three-part question. I'll repeat it, Mr. Aguilar. First, if you guys are a publicly traded company. Second, do you guys provide any scholarships? And then the third, where do you guys see integration in the dental field with online
Dental
treatment?
Yes.
So we are a private company growing rapidly. We have presence right now in the U.S. and some countries in Latin America. In terms of, that's the question about women and
Scholarships. We're talking about
scholarships.
Is the
You know,
second
one of the
question.
things we discussed, we believe in what we call in commercial terms in revenue sharing. We don't want to get rid of the incumbents. We want to partner with all incumbents. And in any instance that a transaction or a patient engagement happens in a particular institution, we share revenue with that patient. For example, if the patient buys medications in a certain hospital, we share revenue of that transaction with the hospital. We work with hospitals to reduce costs in their chronic condition programs. So absolutely we believe in partnerships. We don't want to again get rid of incumbents. We use as many incumbents as possible.
Thank you. We're actually going to have to move on because we're going to have to close the questions up. You can ask right after. I'm sorry. Otherwise, they'll throw me out of the room. That happened last year, and I wouldn't leave, but it was bad. So you, and then Dr. Esteves, of course. Yeah.
Hello? Oh,
Yes.
There I am. Hi. So good morning. I want to thank you all for an excellent panel. That was just wonderful. My name is Dr. Yes, for all of you. Yeah, actually, another round of applause. That was so good. Thank you so much. My name's Monica Rivera-Mint. I'm also from New York City. I'm the proud president of the Hispanic Neuropsychological Society, and I'm also a professor at Fordham University, and I'm at the Icahn School of Medicine. Yeah, well, excuse me?
I'm a Fordham grad.
Oh, yeah, go Rams.
This is a small world.
I'm also at Mount Sinai. And
I went to Mount Sinai. I'm leaving right now.
Okay,
We'll talk.
We'll talk. I do research on brain health in the Latino community, and I'm just curious. I came to this panel really excited to hear about innovations, and given the looming demographics and public health issues in the Latino community, in which Latinos are now the fastest growing aging population. They're aging about 3 times as fast as non-Hispanic whites. And they're also 1.5 times more likely to be diagnosed with Alzheimer's and other vascular dementias and other things. We have a looming epidemic in brain health for the Latinx population. And I'm wondering if in your medical systems, if you've been thinking about ways to prepare for the needs of this population, or what we can do in terms of prevention, treatment, assessment, all of it.
Anyone want to take that question?
Again, today, we are focused on primary care to start with.
Yes.
We're discussing with several institutions who want to include mental health, which is part of primary care, we believe. It's a tremendous problems in many communities. But if you see the future of technology, I think we can start incorporating more and more services and have an early diagnosis of many of those conditions. There are companies around the world, and we are not what we do is try to find the best companies around the world and integrate them to our platform. So the patient only has access to a platform instead of like 10 different companies. But there are many companies that are developing artificial AI for diagnosis, and so we're identifying which conditions are the most relevant to start with.
Thank you.
And then start incorporating those.
Thank you very much.
Thank you.
Yes.
Good morning. My name is Doris Chavez. I'm a research fellow at the George Washington University, and I'm a medical doctor from Honduras. My question is to Dr. Johannson. What's your current opinion on the crisis right now that is happening around the world about measles? Like, why is this happening, do you think? And,
what was the question?
So why do you think the current crisis for measles is happening
Measles.
right now?
Yes.
Yeah.
Why are we in a crisis for measles vaccination?
Ay, Dios mío. People love their children, for the most part. I work at the Centers for Against Family and Sexual Violence, where, I work with horribly abused children. So when I meet someone who doesn't want to vaccinate, I always tell myself, this mother and father love their children.
Yeah.
And they're looking for the best outcome. I tried to say that when I was being struck by La Chancla, but that's not the story. And people, it's interesting how people will believe an impassioned, emotionally and fear-driven message rather than one that's based on evidence. Yeah. And we know this. We know our brain person, and Dr. Fernandez, the limbic system, which is where we make decisions. It's where fear and emotion live, but it doesn't use words. So the anti-vaxxers, they put the crying mom, they put the emotional message out there. And I've had the opportunity to travel from New York to the border, where in certain populations, Hasidic Jews, also wealthy, predominantly non-Hispanic white women who don't want their kids vaccinated. And now there are 1,500 cases of measles in New York City. Yeah. Down where I am, in New Mexico, you don't need to vaccinate to get into school. I'm seeing diphtheria, pertussis, and measles. And you're seeing it around the world. Interestingly enough, most of the migrants that Dr. Gutierrez and I are working with are highly vaccinated.
Yes, they are.
And they show you the little tarjeta. So to answer your question, I think we as pediatricians and healthcare providers need to partner with Hoy and Centene to get the message out there that vaccines are safe.
Right. Exactly.
And that we're not making a fortune. I was, again, challenged on Facebook. The proceeds from my patents go to the Center Against Sexual and Family Violence. Okay. So we need to get that message out. Okay. And thank you for asking that.
Yeah. Thank you so much.
Thank you.
Our
and
last
congratulations
question
to the panel. Wonderful talks. Thank you.
Thank you.
Gracias,
our last question is from our former chair, Dr. Luis Esteves.
Yeah, good morning. And first, I'd like to congratulate the entire panel for a wonderful presentation. It's very inspiring. Thank you. My name is Luis Esteves, and my background is in preventive medicine and public health, but I also train in pediatrics. Yay. And I spent the first 15 years of active practice in the South Bronx, in what I call the southest of the South Bronx, 142nd Street in St. Anne.
Yep. Okay. Boogie down Bronx.
Okay, you know it. And we had a model health center in the Bronx, which luckily was staffed with some of the most brilliant and innovative people, because I basically twisted their arm and told them, you owe the community at least 2 years. Then you can go out and do what you need to do, but you need to come here for 2 years to pay back. And you know what? That strategy worked. And they connected with the community. But specifically, the issue was that when we looked at the immunization rates and we needed to focus on that, what we did is we recruited the patients, not navigators. We recruited the patients to be the advocates, to talk to their neighbors, to talk to their friends, to talk to the naysayers. Bring them with you. Bring grandma who's concerned, or your neighbor, and we got a 97% immunization rate, the highest in the state of any clinic. No money. I'm wondering, I haven't heard that strategy for other, venues, and I'm wondering, this is not so unique. I'm sure there are other models, and I'm wondering if any of you have encountered them.
Well, it goes to what I mentioned earlier with a similar question, is building that rapport. And one of the great myths I try to explain to my Anglo colleagues is that men don't run Latino culture. I get the bisabuela. And once I convince her, then she's the true promodora. And I find I get things that I need done. Unfortunately, I do that with vaccines, and I also do it with end of life. But yeah, and I'm really happy to hear you say you did that, because it created a culturally appropriate venue to increase vaccines. Yeah. And that's what we need to do more of. And I also like that you mentioned it didn't cost money. It took ganas. And that's what we really need.
And, you know, I just want to comment on this issue of your outcomes, all right, for that community. And what it shows is something that we see time and time again, and that is communities really do determine what value health has for them, right? So when a community starts rolling on something, and we all live in communities, right? You know, one of the things that we see in public health is that the word community starts to mean Black and poor or Hispanic and poor, right? But that's not true. Communities exist for everybody, right? There are wealthy communities, there's still communities. But communities determine their health outcomes. So when you value community residents, right, and you give resources, health resources at the community level, you start to see the kind of numbers that you're describing, where community residents start to talk to each other and say, right, that, yeah, I got my daughter this vaccine, right, she's doing just fine. Right, oh, okay, I'm gonna go get it too. Like that, you know, we know as pediatricians, people ask us all the time, did you vaccinate your child? Right, and my thing is, in our wellness centers, first of all, you can't be our patient if you are not vaccinated, because we're not gonna let you put everybody else at risk. Right, right? And secondly, the answer is yes. I don't give a hem and a haw answer, right? I raised 6 children. They all have vaccines. My daughter got the HPV vaccine the moment it came out, right? Because, you know why? Because I don't like cervical cancer. It's just that easy for me. It wasn't a complicated decision, right? Give her the risk of cervical cancer or give her the vaccine. I was good with it. Like that. And as soon as we make it less complex and more about being part of a family, you know, community that makes decisions together and takes risks together, right? 9/11 should have taught us that, right? But as soon as we start looking at ourselves as community residents, right, and as providers, we're residents in the community too, I think it starts to sway the discussion. And for everybody out there, I just want to say one last thing, is remember, innovation is happening everywhere, right? And this really is remarkably the kind of the Google, Apple time of health, right? What Google, Apple, Facebook, you know, tweets, twats, all that did in the in the 80s, 90s, right? That's where we're at in health right now. So innovation should be happening and is happening in our institution, in our traditional institutions. I've never seen more really creative innovation and really creative research in our traditional academic institutions, and I applaud that. But innovation should also be happening outside of those institutions. There's venture capital dollars in health that have never been available before. So if you're thinking about an idea or a solution, go for it.
But we need to partner. Your program is fantastic. I think one of the challenges healthcare institutions and pharma face is how to address these non-white communities, you know? Culturally relevant programs need to be put by us because they don't know, you know? I've been in pharma many years. I've dealt with many healthcare organizations. They don't know how to talk to Hispanos. They don't know how to talk to African Americans. They need our help putting programs like yours. Let's develop probably with the Medical Association a task force on how to help our institutions where we work for, you know, to address that.
So I'm going to unfortunately close this plenary. I think if you want to speak to anyone on the panel, they're there. Thank you all for attending. Thank you, Dr. Correa, for putting this together with your committee. You should give her a hand. This has been extremely successful. And last but not least, please, a great thanks to you as a panel. You really worked very nicely together, and you put up with an addition at the end, so thank you so much.